it's 27 number. So on this evening, we very much fortunate that one big name from our ISN national and international faculty, Dr. J. Balavenkat Subramanian sir, is on our platform. Sir is a senior consultant, academic director, Department of Anesthesia and Preoperative Care, Ganga Hospital and Medical Care Center, Coimbatore, India. Everybody knows our Ganga refreshers course. So it's a not new thing to introduce you, sir, but still it's part of our case. Sir is president presently as Asian Oceanic Society of Regional Anesthesia 2019-2022. He is a founder, president, and current chairman, Academy of Regional Anesthesia of India, national chairman, Academy of Regional Anesthesia of India, associate editor, Journal of Regional Anesthesia and Pain Medicine, governing council member of Indian Society of Anesthesiologists, section editor, Regional Anesthesia, Indian Journal of Anesthesia, editorial board member, Journal of Research Society of Anesthesia and Clinical Pharmacology, post director, Academy Ganga Hospital Regional Anesthesia Guidance Center. Even sir is doing now a fellowship with World Federation of Society of Anesthesia at Ganga Hospital for Regional Anesthesia. Even sir did postdoctoral fellowship also in nerve blocks and pain management at Dr. MGR Medical University. Sir is a section editor of Regional Anesthesia, Journal of Anesthesia and Clinical Pharmacology. Lectures delivered by sir internationally 47, nationally 607, live workshop 32, publications more than 50 in 7 chapters on the anesthesia books. Invited faculty for the following World Congress of Anesthesia, Cape Town in 2008, in 2012 at Argentina, in 2014 again in Cape Town, 2016 at Hong Kong, and Prague 2021. Sir is organizational and academic responsibility. Presently, sir is chairman, National Conference Academy of Regional Anesthesia of India, chairman scientific committee of 15th National Congress of Indian Society of Anesthesiologists, Coimbatore 2002, conference chair Ganga Anesthesia Refreshers Course, the annual national meet since 2015, organizing secretary, National Conference of Academy of Regional Anesthesia of India 2012, Coimbatore, organizing secretary of National Conference of International Trauma Care. Sir, program head of World Federation of Society of Anesthesia, Ganga Hospital Regional Anesthesia Fellowship Program since 2014. 22 fellows from 18 countries underwent this fellowship so far. Sir is post director, Equal Academy, Ganga Hospital Regional Anesthesia Guidance Center since 2005. Has trained 1,472 anesthesiologists through this 1 week observership from India and abroad. Post director, postdoctoral fellowship in nerve block pain management affiliated to Dr. MGR Medical University since 2012, 2 seats per year or 1 year course. Teacher for the National Board of Examination since 2009. Certified CTLS instructor and post director, International Trauma Care Indian Chapter. So as the global advisory panel member of the Smiths Medical Minneapolis, USA from 2014 to 16 for developing new products for regional anesthesia and infusion systems. Visited USA twice every year for this activity for 3 years. Principal investigator of the EPOC committee, sponsored the first multicentric trial on post-operative analgesia involving 12 centers in India, Bangladesh, and Sri Lanka. Awarded the GSC scholarship by Rotary International and visited Seattle, USA. Sir has delivered a number of orations, and it's very huge work done by sir. And awards. Academic Excellence Award for year 2017 presented by Honorable Health Minister of Tamil Nadu in a function organized by IIM Tamil Nadu State. Sir is alumni of BJ Medical College. He is a Best Postgraduate Award for the year 1990. University first in the qualifying the examination, Pune University in 1990. A lot of what I can say is achievements, and if I started completing all words, then I think our meeting with sir will be delayed. So I want to stop this and I will allow sir to share the screen. Sir, please.
Good evening, everyone. Thank you, Dr. Prahalad, the president of ISA Nanded, and Dr. Sachin, the dynamic secretary of ISA Nanded, for inviting me and giving me an opportunity to share some of the thoughts on one of the most common clinical problems that we face as anesthesiologists in India today, and more so in rural areas. I chose a picture which is probably taken in the way back in 2003. I chose this because this patient was 104 years coming for a hip fracture. So I continue to use his picture because he depicts what geriatric means and what hip surgery means. And the third common cause for which a patient above the age of 65 years gets admitted for a surgery in India currently is hip fracture. So I thank the ISA Nanded for doing this weekly webinars on every Friday to commemorate their silver jubilee of the ISA Nanded city branch and also the platinum jubilee of ISA National. I thank them for disseminating this knowledge and information because I think it's extremely crucial to update ourselves and to make sure that whatever we learn through this webinar, we implement in our clinical practice for better outcome of the surgical patient. I bring to you greetings from Ganga Medical Center and Hospital, Coimbatore. Currently, it's a 680-bedded tertiary care referral center for trauma, orthopedics, major spine surgery. And we currently have 38 operating theaters, and we do close to 125 surgeries a day, of which every week we were taking a statistics. Every week we closely do about 40 to 45 hip fractures every week. That's the statistics. And one of the most important things that I always wanted to emphasize is that all these patients with hip fracture, when they come to the hospital, the geriatric hip, they come with such significant pain, and we have evolved a system that on arrival for all the hip fractures, we give a block. Initially, it was a femoral block. Now, later with the advent of ultrasound, we went into the fascia iliaca block, of which now we go to suprainguinal fascia iliaca block, and currently the pericapsular block or the PENG block. So the minute you do that, the comfort level of the patient goes very high. So that's why I always think that we are true angels and we shouldn't allow any patient to suffer of significant pain. So we evolved a system where immaterial of what time a neck of femur comes into the hospital, even if it's at 12 midnight, the anesthesiologist, the protocol here is they'll get investigated, and if there is a hip fracture, will be assessed by an anesthetist. All that is needed to correct the internal milieu will be done, including a on-arrival block. And this is something which has completely changed the outcomes. This is our firm belief. And hip fractures are one where anesthesiologist role is very, very significant. And since 2002, for the past 20 years, we have kind of taken over the perioperative care of all our patients, including preoperative assessment and optimization, intraoperative care, and postoperative management of all the facets of a geriatric patient. And I think this group of individuals with hip fractures pose the greatest challenge, needing phenomenal contribution from anesthesiologists. And I think this is a true example of anesthetist to work as a perioperative physician. The reason why we need to take the lead is if more than one specialty is involved in treating a patient, especially hip fracture, there is going to be a complete chaos, and the timing of surgery, when to do it, what drugs to start, what antibiotic to give. At every single instance, there seems to be a conflict and difference of opinion between the multiple specialists. And hence, if we take the lead we can get an opinion, but the decision making should be with the anesthesiologist. And I have introspected a lot, and I think we are the only specialty which has got a great knowledge about the physiology and pathophysiology right from a premature child to a centenarian. And we have a thorough knowledge of several comorbidities that is associated when you treat the centenarians, the polypharmacy that is associated when you treat the geriatric patient. And we also learn a lot about the various drug interactions. And we have been for ages been closely associated with treating the critically ill, the trauma patients. And we have got a lot of insights into invasive monitoring, assess the internal milieu dynamically in the intraoperative period. Slowly, many anesthesiologists have become extremely good in echocardiography, E-fast. We have started interpreting the thromboelastography, the flow volume loops, the arterial blood gas analysis, the depth of anesthesia, and now we are moving towards various facets of ultrasound use in clinical practice like airway ultrasound, gastric ultrasound. We also have become the number one in fluid therapy, total parenteral nutrition, blood component therapy, in the perioperative care, chest physiotherapy, mechanoprophylaxis for DVT, acute pain management, a knowledge about elective ventilation, weaning from ventilation, percutaneous tracheostomy. We do intercostal drainage, bronchoscopy, ACLS, arrhythmia management, code blue. So if we see, I think our branch is extremely versatile, and we have become extremely unique because of the multiple perioperative interventions that you can make. I think no other specialization can claim that they look after so much of a patient. And if you see whatever I dealt with, it clearly depicts the vast amount of inputs that we give to the hospital. And I think we should call anesthesiology the mother of modern medicine. Ronald Miller is very popular, and each one of you know him. He said in the American Society of Anesthesiologists created a task force to identify possible anesthesia paradigms in 2025, headed by Ronald Miller. And he emphasized that anesthesiologists need to diversify their practice paradigm in order to ensure a future leadership position in medicine. So I think perioperative care is the one which will give us the leadership position. And whether you're practicing in a corporate hospital or whether you're working in a small hospital, each one of us here should make sure that quality of anesthesia is ensured. And this is a brilliant article by Lee Fleischer. And I would want all of you to go through this and just read the first couple of lines. Quality has been defined by 6 domains. What you offer to your patient should be very effective, timely, efficient, equitable, safe, and completely patient-centered. So this is the current concept of quality of anesthesia, and I cannot emphasize more than what we do it for a patient with hip fracture. India, with the population close to, it was 75 million, and now I think the latest statistics is close to 90 million geriatric patients are in India above the age of 65 years. So the reason why we need to become familiar with this is we are going to see much more thanks to the advancement in disease control and also the medical help people get even in rural areas, that people live for the 8th and the 9th decade of life. But if you really introspect, when you see 2 newborn, they are so identical. You can't just differentiate between the 2. They are so similar, but as they grow, they become completely different because of various factors, including genetic factors, environmental factors, and the activity of daily living, incorporating yoga. So what happens is there is 2 completely identical newborn mature out into completely 2 different individuals who are absolutely heterogeneous. So from homogeneous, we go to heterogeneous. I think this is something extremely unique, and the life expectancy changes based upon various influences that has, including socioeconomic. All of us would like to be like this always, but then when the time goes on, you need to accept that you're getting old. I'm sure you and me wanted to be the one on the left, but as we grow, then we slowly progress towards the right end. But it's also important to know that you may be chronologically old, but you can still remain physiologically young, and the outcomes are excellent in neck of femur fractures if you're physiologically young. So this is a patient who is 95 years old, came with a hip fracture, but absolutely with excellent internal milieu, with able to see, able to hear, and he can comprehend, communicate. We only wish that every geriatric patient is like him with no comorbidities. But always we are challenged by the hip fractures because they have decreased organ function and poor reserve. What exactly this means? The 40 years is the watershed. After 40 years, every year a person lives, there is 1% decrease in the organ reserve of every organ in the body. So suppose you are anesthetizing a patient who is with 80 years, it means he has lived 40 years after the 40th year, which means 1% loss of organ function. So 40% of his liver is not working, 40% of his kidney is not working. So there is a gross reduction in the reserve of the organs as we age. And this becomes worse with the comorbid conditions. Above the age of 40, the incidence of diabetes, hypertension, coronary artery disease, cerebrovascular accident, bronchial asthma, Parkinsonism, lot of degenerating and demyelinating disorders, everything contribute to further decrease in organ function and organ reserve. And to correct these disease and disorders, we physicians put them on multiple drugs, and polypharmacy itself produces a lot of side effects. And in general, when you deal with a geriatric patient, you have these three things in mind. And perioperative medication management has become a big subject by itself, and it's extremely true of a geriatric patient. As an anesthesiologist, we need to spend significant time to understand not only the comorbidities, but also to look into what are the medications that this geriatric patient is taking and what is its implication in the perioperative period. And this is something which I wanted to share with you. One of the biggest challenges that face a geriatric patient when we anesthetize is the cognitive dysfunction. So I want all of you to go through this very nice initiative, the Perioperative Brain Health Initiative by American Society of Anesthesiologists. This is a very good read, and I just want you to read this, perceive it, and try to implement it in your geriatric practice. So when you deal with a geriatric hip, it's like a very frail patient. It's like they are almost near the end of the journey, like this vehicle, and they have so much burden. And the challenge is we need to make sure that this vehicle runs and we discharge them back home. So now the first question, many of them ask me, if the patient is very old and sustains a hip fracture with multiple comorbids, is it better to operate or allow them to just lie down in the house? Now, the data is very, very clear. If anybody asks you this question, or if you're confronted with taking a decision of doing a surgery for a relative with hip fracture, the answer seems to be a very big yes. Surgery provides effective analgesia, and surgery should be done until otherwise the patient is so sick that he may succumb within the next 48 hours. Otherwise, it's like a palliative care. Surgery has to be done for hip fractures just to produce effective analgesia. Otherwise, the patient is going to really suffer, because even little bit turning will produce intense pain. And this is something which all of us have to take into consideration. We need not worry about his mobilization protocol, whether he'll be able to do activity of daily living. All that is secondary. All the main reason that why we need to do the surgery is to produce effective analgesia. Now, what happens if you don't operate this patient? This is an excellent statistics. It says, this is a 2020 statistics, which says 48.6% of those who got admitted in the hospital never gave a consent for surgery died, versus only 6.6 after surgery. So this clearly indicates that there is a huge role to be played by the surgeons and the anesthesiologist in recommending a surgery for hip fracture. Next question is, how early should you operate? The answer is, the outcomes are excellent if you do it as early as possible. Several guidelines exist, but the best results are seen when it is done within 36 to 48 hours. That means within the first 2 days of admission into the hospital. For me, being into orthopedic practice for the past, since 1995, so it's 27 years, and I am one who want to do a hip fracture immediately on arrival, except if there is some drastic physiological, pathophysiological intervention that needs to be done to correct the internal milieu. But otherwise, I am one who wanted to get the surgery done at the earliest. Here, again, I would like to quote, I know this is a forum which consists of people in private practice. One of the biggest deterrent on timing surgery for hip fracture is many of these patients are on antiplatelets and anticoagulants. Now, there is a big debate is going around the world. Do we wait for 5 days for the antiplatelet activity to come down and then take him for surgery? But we know the results. The morbidity and the mortality might be high if you're going to wait for a long time, versus getting a written informed consent about two things. One, the neuraxial block can produce an epidural hematoma, but the incidence is very less. Number two is there can be slightly more bleeding in the intraoperative period. So now it is left to the team to decide which one they would like to offer. And I would want to convey to you that in my unit, when I am involved, I explain to the attenders about the consequences of waiting for 5 days versus getting it done. I get a written informed consent and I go ahead and do the case in spite of these patients or on antiplatelets. This is something which I wanted to share with you, but this is up to you and to your team, the surgical team, to collectively decide the path that you're going to take. But also I wanted to tell you that there are several articles which says that within 3 days, like for example, the aspirin, now it's very clear, even if the patient is on 75 milligram, 150 milligram, there is no contraindication to do a hip fracture under a neuraxial block, no contraindication. But if it is the drugs like clopidogrel, normally it's at 5 days, but now slowly it is getting proved that the amount of platelets that are produced reach a level which can produce a good platelet flux within 72 hours. So this again, I want all of you to read more on the literature and then get a consensus statement with the surgeon before you decide. And also now you see a lot of patients on direct oral anticoagulant drug, and these are all defined. And what is the current recommendation? Current recommendation is two half-lives. You wait for 2 half-lives. Suppose if the half-life of the drug of the oral anticoagulant is 6 hours, you take the patient after 12 hours. And if the patient is on drugs like warfarin, the best thing is you can, for example, if the INR is more than 1.5, you should give 15 ml per kg body weight of fresh frozen plasma and go ahead and do the surgery under neuraxial block and continue vitamin K. So in other words, I'm trying to emphasize the need to do early surgery in hip fractures trying to find out solutions to the challenges that are posed, which would prevent you from going in for an early surgery. The reason I'm emphasizing this is the outcome seems to be excellent when you operate the earliest. So when the patient comes in as an anesthesiologist, the most important thing is, as I discussed, on arrival block. Second important thing is, because of the fracture, majority of the Indian geriatric patients do not eat and drink for fear of passing stools and urine. And they dread doing that because even little bit movement produces significant pain. And hence, they keep them highly dehydrated. So this results in pre-renal azotemia, acidosis. So I would strongly recommend the next thing that you would do is start an IV cannula and hydrate the patient and immediately catheterize the bladder to make sure that you get at least 1 ml per kg body weight in a geriatric patient. If you don't do this, many of them have retention of urine, and this is one cause of delirium. So hydration, pain, distended bladder, fully loaded bowel. So you need to go for a suppository and empty the bowel. If you do all this, the chances of developing anxiety and cognitive dysfunction is less. And next important thing that you have to see in this patient is the hyponatremia, which is associated with several hip fractures. And you need to make sure that you keep it around 130 milliequivalents, and you need to correct it if it's low. So as I said, pre-renal azotemia is because of decreased fluids, and always there is a rise in urea and creatinine level. And it's very important to look at the investigations that you do for geriatric patients. And usually the IV fluids would correct the urea and creatinine, and it becomes normal. And what do you do next? Very important to see the fracture pattern. This you learn a lot as an anesthesiologist when you see the fracture pattern. What are the different types of hip fractures? See, number one, I just wanted to show that this is the pelvic bone, and this is the acetabulum, and this is the neck of, this is the head of the femur, the neck of the femur, this is the trochanter. So now the fracture can happen anywhere here. All of them are classified as hip fractures. So here, if you see, it has happened between the head and the trochanter, and this is a undisplaced neck of femur fracture. Next. So if you see, now the fracture has happened in the intertrochanteric region with a subtrochanteric extension. So either you can have a neck of femur, or you can have a trochanter fracture or a subtrochanter fracture. So what actually you learn from this? For a patient to get a neck of femur fracture, the amount of physical trauma that he should sustain will be very trivial. He sustains it. That means all those who are having a neck of femur fracture, the postulation is they had a poor activity of daily living, and they're very osteoporotic, and their outcomes may be bad. But to develop a fracture like intertrochanter with subtrochanteric extension, the bones are pretty strong, but they had such a strong physical impact. They're not very osteoporotic. Their activity of daily living is normal. So the outcome post-surgery might be better. So you clearly get an information about the outcome based upon what kind of fracture they have sustained. So if you have to be doubly alert if you're treating a neck of femur fracture, and the subtrochanter and the intertrochanters, they are much better. They do pretty well. So neck of femur, the blood loss is less, but in subtrochanter, the blood loss is more. And in neck of femur surgery, the need for putting cement is more. In subtrochanter fracture, the need for putting cement is less. So when you see this X-ray, immediately based on the clinical condition, you would discuss with the surgical team on the various facets of the surgery, especially if it's neck of femur. You will ask whether it is cancellous screw, hemiarthroplasty, or whether this is cancellous screw the simplest. And there are no major concerns if you deal with this. There's no major change in internal milieu. But if you have to go for a hemiarthroplasty or a total hip replacement and cement usage, which you see lot of cement that's been put here. These are all the cement that you see, and the consequences of putting cement inside a sick patient. We will come to it later, but what I wanted to emphasize here is it's important to know the fracture pattern. It is important to know what the surgeon wants to do, and it's important to devise a strategy along with surgeon to know the intraoperative requirements. And decision to use an uncemented implant should be taken in the preoperative period and explained to the patient, because all the sick patients, I think it's important a decision is done and informed consent is obtained regarding this. And this just to show on arrival block, she's a 96-year-old lady who came with significant cognitive dysfunction and came nearly 6 days later. These are all pictures which were taken much, much early when we started perineural catheters. And just see her after 6 hours of putting a perineural catheter and an elastomeric infusion pump. These are the prize cases which we preserve because the outcomes had been excellent. She went on to live until 102 years. And informed consent, especially when you're in private practice, it becomes very, very important that all of you should learn and read more about the informed consent, because it's becoming increasingly important even in India that we need to be absolutely transparent. And I think the anesthesiologist also should partake, explain to the patients what they are going to do and what are the expected complications. In our unit, invariably the surgeon also talks to them and anesthesiologist also talk to them and explain to them the various possible complications that can happen because of the intervention, and we get a consent. I think I consider this slide very, very important. And when you do a pre-anesthetic assessment, there are several things that complicate geriatric assessments because of the chronic diseases that they have, and 30% of them have more than 3 diseases. And one system's acute illness stresses others' reserve capacity. One disease's symptoms may mask the another one. One disease treatment may mask another symptom. So it's a kind of being in a maze, and it needs an expert to decipher all this. And also, we don't get clear history many times because of the communication problem. And many of the geriatric live alone in India nowadays. So neither they are able to tell exactly the issues, nor the patient attenders, because they don't live with them. And this I said, and I wanted to emphasize too much, polypharmacy, you really need to go into that. Now, preoperative concern. The next biggest step that an anesthesiologist need to take is when you deal with a hip fracture, there has been a history of fall and the patients are very frail. So you also have to know if there has been an associated injury, especially if they're on antiplatelets and anticoagulants. And one of the things that you need to ask them very clearly is cause of the fall, whether there was a momentary loss of consciousness which resulted in the fall, or after the fall, whether they had a loss of consciousness. This is something very crucial, very important to know why the patient fell down, and also to make sure that we good remedial measures for that. And if there was a loss of consciousness and a fall, then the investigations that we need to be done include a corrected Doppler, and you wanted to know vertebrobasilar insufficiency, or the patient had a middle ear disease. But if the patient had loss of consciousness after the fall, it's got great implications to anesthesia, because patient may have had a head injury, including a subdural hematoma. The commonest cause of change in conscious level in the postoperative period, not delirium, but loss of consciousness, GCS going down in hip fractures, is an associated head injury, especially a subdural hematoma. And as we know that it's very difficult to assess the cardiorespiratory reserve in this patient. And also, many of these geriatric patients have associated osteoarthritis, and for years together, they're on multiple medications, including non-steroidal anti-inflammatory. So their kidney reserves may be really, really poor. So the goals of preoperative optimization is currently globally with the minimum time available for hip fractures, you need to go for excellent multimodal rehabilitation. And it involves good physical activity, especially the deep breathing exercise and incentive spirometry, and also quick nutrition. They have and a psychological support to the patient. These are few things that need to be done as you're preparing the patient for a surgical procedure. So the goals, now we are ready to go for surgery. The preoperative optimization include hydration, electrolyte imbalance, especially sodium, potassium, bicarbonate, and calcium and magnesium. You need to have a hemoglobin around 10 grams. The outcomes are very good. If it's less than that, you may have to transfuse them prior to the surgical incision. A close monitoring of the urine output, so the bladder to be catheterized, a close look at the coagulation profile, adequate analgesia, and albumin. Albumin seems to be a great predictor of outcome, and albumin levels of less than 2 grams clearly indicate that their nutritional levels have been very poor, and or they had a good nutrition, but there has been malabsorption. Whatever be the cause, these patients' morbidity and mortality seems to be high. And similarly, on arrival in trauma, which you can, if they come after some time, if they're very dehydrated, you may also see the lactate level. If the lactate level is more than 5 millimoles per liter, it indicates the tissue hypoxia, and you need to resuscitate this patient by giving fluids. This is called as microcirculatory resuscitation. BP is normal, but there is acidosis. So it happens in few geriatric patients who come late to the hospital and who have not taken, who didn't have adequate hydration. So this equipment should be a part of every incentive spirometry. The minute you see the patient, give the block, hydrate, and start incentive spirometry. So these preoperative optimizations are very important. And this is something very recommendation for patients to take for surgery. Hypertension is one of the common comorbidities, but the current recommendation is you can accept a systolic of close to 180 and a diastolic of more than around 110 in a geriatric patient, and there has not been a bad outcome. And this is because of the atherosclerosis that they have developed, and the perfusion pressures have to be maintained to the organs. And so there is a climb in the systolic pressures. And this is a proven data that you shouldn't postpone a case when you see these figures. I recommend you to read more on this if you have any questions. And once you're convinced, then you can follow this protocol. I, for one, will not postpone a case seeing the pressures at 180, 100. And if you're dealing with a geriatric patient with heart failure, you need to go for the biomarkers, mainly the pro-BNP. And murmurs are very common in geriatrics. So if possible, we'll get an echo done. Most of the time, either it's a hemic murmur or the problem is in the aortic valve. And many of them might be on the pacemaker, and you need to have a look at it. And they have iron deficiency anemia. So all of our patients, we start them on B12 and folic acid the minute they arrive. Though the surgery is happening immediately, this is a part of the process of rehabilitation. So we put them on oral iron and folic acid for 30 days. And if these patients are alcoholic, we always start them immediately on thiamine, 100 milligram eight-hourly. So this is something which I wanted to say. The cognitive dysfunction and the delirium they develop in alcohol withdrawal can be reduced by adding thiamine 100 milligram eight-hourly the minute they come to the hospital. So now, which anesthesia is best? Is it regional or general anesthesia? Of course, based on the literature, there's hardly any difference between if you see the 30-day mortality, there is no difference between neuraxial block and general anesthesia. But then I'm actually looking at the infrastructure that is available in various surgical setups across India. And you would agree with me that regional anesthesia might be preferred, especially in centers which do not have, in smaller hospitals, which do not have a high dependency unit, or which does not have an intensive care unit and closely being monitored by qualified personnel. So in which case, regional seems to have an edge over general anesthesia in terms of perioperative care and postoperative care. So in regional anesthesia, for me, the choice in hip fracture for time immemorial has been a combined spinal epidural. But before we do that, as I said, we do an honorable block. And if you have not put a catheter, if you're going to do the surgery in another few hours, if it is more than 6 hours, we repeat the block. And we add an adjuvant, that is dexamethasone 4 milligrams, along with the local anesthetic agent for one of the blocks that you gave. And once you have given a block and then position for neuraxial block, believe me, the neuraxial block becomes very, very easy because you're able to position the patient without pain. Without a block, when you try to position the patient is very uncooperative, a degenerative spine, sometimes with kyphoscoliosis. It's so difficult to give a proper neuraxial block. So I would strongly recommend and advocate that you do a preoperative block, femoral block, or a PING block or a fascia iliaca block, and then position the patient. And my choice is to go for combined spinal epidural and patient in sitting position, because the interspinal space is much, much better in sitting position. And once you give the block, it's very, very easy to position them sitting rather than the lateral position. And I prefer combined spinal epidural because of the fact that you can give very low dose in neuraxially. This is something which I wanted to strongly emphasize, and there is a lot of literature available on giving very low dose. Several studies have been done with bupivacaine, and what I do is above the age of 100 years, I give 0.5% bupivacaine, heavy only 0.6 ml. Between 90 to 80, I give based upon their height, I give somewhere between 0.8 to 1 ml. Between 80 to 90 years, it's about 1.2 to maximum 1.4 ml. Between 70 to 80, I give maximum as 1.8 ml. So I give a very low dose neuraxially. The biggest advantage is you make sure that the mean arterial pressure is maintained and the organ perfusion is maintained. So one simple statement which I wanted to say and which I've learned over years is try to maintain the mean arterial pressure equal to the age of the patient. If it is 80 years, maintain the map at 80. If it's 90 years, map at 90. 100, map at 100. You will see the organs are perfused and the perioperative complications becomes less. There are several studies which indicates that in a geriatric patient above the age of 80 years, if you have kept a mean arterial pressure less than 80 for more than 10 minutes, it can result in organ hypoperfusion, and not immediately, but after 24 to 48 hours, you can see issues happening because of multiple organs. So what I would strongly recommend is to go for a combined spinal epidural, low dose spinal, and then epidural. When you do a combined spinal epidural, the 2-segment regression, when you do with low dose, the 2-segment regression happens within 45 to 60 minutes. So it becomes mandatory that you start topping up the epidural catheter with aliquots of local anesthetic. Like each lumbar segment will need 1.5 ml. So you need to give 3 ml. So you gave 1.5 ml of 0.5% bupivacaine heavy to start with intrathecally. And then after 45 minutes, you start topping up the epidural catheter with 3 ml aliquots. And every 20 minutes until the surgery is over, you give them this 2 ml aliquots to compensate for the 2-segment regression that takes place. Now, you need to give fluids and more importantly, vasopressors to maintain the map. And several studies have indicated that the preoperative blood pressure, there should not be a fluctuation or a fall more than 20% of the preoperative pressures to maintain the perfusion to the various organs. So this is about the pre-op femoral block and combined spinal, which I spoke. And regional anesthesia seems to be advantage in several ways. Decreased stress response to the trauma, tissue trauma, decreased blood loss, and because we don't give much of sedatives like GA, the the tidal volume and the ability to take deep breath is very good, and postoperative hypoxemia is less. Incidence of nausea, vomiting is less because of early mobilization. DVT is also less. In all our patients, we go for mechanoprophylaxis to prevent deep vein thrombosis. Bilateral, they're on intermittent pneumatic devices. And it also works as a preemptive analgesia, regional anesthesia, especially the block that you gave. And you're able to position the patient, and the post-procedure, the patient is able to take any position, left lateral, right lateral, sitting. All this is possible, and this prevents pressure sores from happening. And there's a great sense of well-being, good sleep is produced, good appetite happens. So I think regional anesthesia, according to me, in Indian scenario is far superior to general anesthesia. But again, with the advent of all the modern gadgets, including good workstations, short-acting anesthetic agents, total target control infusion, total intravenous anesthesia, inhalational agents like sevoflurane and desflurane all seem to have contributed for a better outcome even after general anesthetic. But if you want for some reason to avoid a sentinel access block and you wanted to give general anesthesia, still I would strongly recommend that you would go for GA with a block to make sure that regional analgesia becomes a component of multimodal analgesia, and immediate postoperative period is extremely comfortable to the patient. So the intraoperative monitoring, which all of you will be doing, is to go for the pulse oximeter, 5-lead ECG, especially for ST analysis, especially if there is coronary artery disease. 5-lead ECG is important. If you only have a 3-lead ECG, then you have to go for the modified chest lead based upon which particular wall of the heart that you want to monitor based on the previous history. Then if it's in IBP is needed, especially in where you think that the patient's cardiovascular status is poor, especially previous coronary artery disease with an ejection fraction of less than 45%. I would strongly recommend to go for IBP, or in surgeries where you expect a lot of blood loss, you go for an invasive blood pressure monitoring. And temperature, because they're highly prone for hypothermia, and urine output has to be monitored very closely in the intraoperative period. And when these hip fractures, especially the subtrochanters, they have very vague positioning happening in the fracture table. Whenever you deal with this and when the patient is sick, always keep a stretcher outside the operating room, because you can't do a CPR in this table. So if at all needed, mentally you be prepared to get a CPR done when you deal with the fracture table. And a drug that we use to decrease the intraoperative blood loss is tranexamic acid. And all these patients, we start with 1 gram in the preoperative period. So tranexamic acid up to 3 grams in a geriatric population has proved that very effective, and it is not producing any thrombogenic, have not produced any thrombogenic event. And when you want to do a blood transfusion, as I said, the transfusion trigger depends on the unit, but we keep it in geriatric patient with cardiorespiratory reserve as 10 grams %. And the blood product that we wanted to give is leukodepleted packed cell. I'm addicted to leukodepleted packed cells because if you give the blood with the WBCs, there can be a fever spike, and one fever spike is enough to take in a frail patient to take away the advantages. So when it is available, I think I would strongly recommend to go for a leukodepleted packed cell. The next biggest challenge comes not a component of subtrochanter, not a component of undisplaced neck of femur, but when it happens with a neck of femur with hemiarthroplasty to be done with the cement, here is the next biggest challenge that you're going to face. And we discussed, if it's going to be a sick patient, you're taking a decision that you will not go with the cement, but you also compromise that there can be loosening of the hip, there can be pain while walking. So here you have to do a trade-off between an intraoperative critical event versus the surgical outcome. And this has to be taken a combined decision with the surgeon and the patient attendants. And intraoperatively, as I said, we need to look after. So this is an online fluid warming. We use Barhaggers to surface warming to make sure we maintain the temperature of the patient. And postoperatively, the most important thing is pain, and we need to go for multimodal analgesia. In geriatrics, the most important component of multimodal analgesia is regional analgesia plus paracetamol. Non-steroidal anti-inflammatory drug should be used with caution, especially because of the renal parameters, and patients with diabetes, the incidence is high. There could be, so before you prescribe a non-steroidal anti-inflammatory, make sure the renal function is normal. And if the creatinine and urea is normal, look at the urine. If there is even 1+ albumin, then I don't think you should start a non-steroidal. So the opioids, again, are not highly indicated in geriatric population because they're a part of cognition, cognitive dysfunction, and respiratory depression. So the mainstay I would prefer would be going for regional analgesia with steroids. And when they're bladder catheterized, it's a good option when you do with a combined spinal epidural to go ahead with elastomeric infusion pumps. We use 0.125% bupivacaine with 2 microgram of fentanyl per ml, given at a rate of about 6 to 8 ml based on the requirement. Multifusers are available now, and I think elastomeric pumps are a great boon for this geriatric population. So paracetamol, we go up to 3 grams when they're more than 90 years with normal renal function, but from 70 to 90, we go up to 4 grams if the renal parameters and liver parameters are normal. So we spoke about regional analgesia and site-specific analgesia. These are perineural catheters for hip fractures. Then we put them on elastomeric infusion pump. And one of the important thing that I spoke about is delirium. And the most important thing is you need to avoid the anticholinergic load. And that's why if there is a bradycardia, we should never give atropine and this, prefer glycopyrrolate than atropine. And if there is a delirium, you need to rule out hyponatremia, hypoxia, hypotension, hypoglycemia, and look at good pain relief. Always keep in mind the possibility of head injury and alcohol withdrawal. And so we said we need to put them on thiamine supplements. DVT is not as common as in younger individuals, but it's a great idea to go for mechanoprophylaxis. And if they're going to be bedridden for a long time, you can think of starting a minimum an antiplatelet 75 milligram once daily for 30 days if they're from remote locations. But if they're obese, I would strongly still recommend to go for low molecular weight heparin like enoxaparin. So the commonest problem that we see is hypostatic pneumonia, pulmonary infection, and when you transfused blood, sometimes transfusion-related acute lung injury. So always keep a close watch on the renal function, and it's very important to increase the morale of the patient to go for early mobilization, good psychological support, look after the bowel and the bladder. Even if one day they don't pass their stools, they get so upset and they're very anxious, they don't sleep. So it is a dictum that all of our geriatric patients in the postoperative period, when the anesthesiologist writes the notes, always we make sure that a laxative is included in that. And we need to be closely following the perioperative antibiotics. So all the challenges with hip fractures can be converted into good outcome of better understanding of the physiology, better pharmacotherapy, safer anesthetic techniques, improve the monitoring status, go for multimodal and site-specific analgesia, good physiotherapy and early ambulation. All this will result in excellent outcome to our patients with hip fractures. So this is in a nutshell a bird's eye view of what we have learned over years on dealing with hip fractures and how to make sure that you decrease their morbidity and mortality and try to maintain their functional capabilities so that they are very productive. So step 1 is to make them pain-free. Step 2 is to make them independent. And with very careful perioperative care, this is a possibility even in patients who are sick. Thank you very much for the opportunity. And I'm open for any questions that are going to come.
Thank you, sir.
Yeah.
There is one question in chat question answer box from Dr. Abhijit Nair. Respected sir, recently Dr. Adamir strongly opposed the findings of a big study published in NEJM saying that the conclusion are not justified. The study is titled Spinal Anesthesia or General Anesthesia for Hip Surgery in Older Adults by Newman et al. The study concluded that spinal anesthesia for hip fracture surgery in older adults was not superior to general anesthesia with respect to survival and recovery of ambulation at 60 days. Sir, what are your comments on this?
Actually, this is a big global controversy that keeps going between neuraxial block and general anesthesia. But as I said, we are speaking to, as I told in my talk, we cannot take what the West tells always because they do not know the infrastructure that we have. They do not know that every patient in the postoperative period is looked after by a staff nurse who is very qualified. He's not sure whether we have a multi-parameter monitor. We're not sure whether we have a suction apparatus, if there is a regurgitation happening. So we are confronted with a situation where there are several limitations when you provide general anesthetic to your patient, not in the corporate unit, not in the big hospitals, but hip fractures are done across the country, even in the smallest of small hospitals. And we need to take this into consideration. And I personally feel there is no difference between GA and neuraxial if you have the best of abilities and best human resources. But if not, I think still neuraxial will hold good because overall outcome and patient going back home is very crucial and important.
Next question from Sushil Krishnan, sir. Thank you for your good insights. Example, the use of leukodepleted blood, use of laxatives. He's asking, what is your opinion on using catheters with the PENGs, PENGs? Yes, Krishnan.
Use of?
What is your opinion on using catheters with the PENGs?
With PENG block?
Yes.
Yeah, we have not, I don't have any person, we don't, in our institution, we have not used PENG catheters. And, but all the time we add dexamethasone as an adjuvant to the local anesthetic solution. And we have found good analgesia for close to, our audit indicates close to 16 to 24 hours. I personally have no opinion, nor in our institution about PENG catheters because we don't use it.
Next question from Sonu Balsara. Can you please talk a little in detail about use of cement and its complications?
Well, can you repeat the question?
Can you please talk a little in detail about use of cement?
Cement.
And its complications. Yes, cementing and its complications.
So the bone cement implantation syndrome is one of the complications of neck of femur fractures. And what exactly happens is when there are a lot of surgical techniques which has come out, which has given, especially when they don't pressurize the femoral canal with cement. Now we have guns to put cement inside. So the femoral canal, the pressure inside the femoral canal doesn't become too high. But what do an anesthetist expect? So the bone cement implantation syndrome is the cement, the marrow, fat globules, they enter the venous circulation and they go and get filtered in the lung, and results in increased ventilation perfusion mismatch. And also they have the ability to decrease the systemic vascular resistance and hypotension. And so here you are dealing with a situation of decreased in the afterload, myocardial depression, and a hypoxic episode because of ventilation perfusion mismatch. This can be tolerated by a person with a good activity of daily living, but it will be a question in a frail individual. One episode of hypotension can produce the consequences of organ perfusion, including the coronary perfusion. And hence, there are several studies which indicated that you need to take a call on frail individuals, whether do you need to take a chance of using the cement or accept. As I said, it's a palliative surgery, like mainly to decrease the pain on movement. So go for an uncemented implant without the cement at all. So the complications are hypoxia, hypertension.
Next question from Dr. Shobha. Should we give them dentures, glasses, hearing aids post-op? How much should be NBM period?
No, number one, all the aids should be inside the operating room itself, the hearing aids, the spectacles. There's no need to keep them in the room. In fact, we strongly encourage them to have it in the intraoperative period and in the post-operative period. So this is a policy decision that needs to be done. It's a small thing, but it's important to keep the communication on. So that's about the devices that needs to be done. And regarding the hydration component, suppose you have done with the low dose centinuraxis block with an epidural catheter in situ, and you have not sedated the patient at all, you can actually start. If you see by the time your patient comes, the surgery gets over, neck of femurs usually anywhere, depending on the expertise of the surgeon, would be anywhere between 30 minutes to 2 hours. And you see that I said 2-segment regression happens within 45 minutes, and then it's only the top-ups that you keep giving. So essentially, if the patient is conscious and oriented, if you make them 30 degrees head-up tilt, you can actually start oral liquids within about an hour's time. And sometimes if you see, I've started it immediately because it's all under supervision. And I have never seen, the only concern is if they're sedated, the aspiration or the regurgitation, but give a 30 to 45 degrees head-up tilt, start them on sips of clear water, because they're extremely uncomfortable when they are very parched, and when they have a dry mouth, they can't speak. So these are things which I've noticed, and under supervision, I think clear liquid, especially water, can be started very early based on the comfort levels of the infrastructure that you have and the good nursing staff you have.
From Dr. Punahudi, sir is asking fascia iliaca block or ping block. Which block you will choose first for the patient?
It depends on the expertise. I would recommend both, because our audit indicates the analgesic component of both ping block and suprainguinal fascia iliaca block are almost similar. But only thing is, you need to be an expert to do a ping block. Suprainguinal fascia iliaca block is more simpler. Complications will be less. But here, the viscera is very close by, the urinary bladder. And you shouldn't injure any visceral structure inside. So it's all based on your expertise. But as far as analgesia is concerned, we don't see a great difference between the two. They're almost equally good in producing a good quality of analgesia.
From Dr. Anuradha, bupivacaine or ropivacaine, which is superior to combined spinal epidural?
For the doses that we are using in combined spinal epidural, for me, the greatest amount of the number of cases they've done with this bupivacaine, I'm extremely convinced that it's a drug that can be used very safely, with very effective. So even after bupivacaine came, in geriatric hips, I still go with bupivacaine with the doses that I standardized. So my choice would be bupivacaine.
What is the cutoff limit for ENT pro BNP for pre-op and post-op period?
Ideally, you know that if these biochemical parameters are elevated, there is going to be, this is something to do with the cardiac function and the pumping. If it is preoperatively, you have noticed, I would still say that you enhance your monitoring standards and go ahead with the surgery, because again and again, the most important thing is to make them pain-free. If it happens in the post-operative period, there is no cutoff. It's very difficult to say. Large trials are needed to talk about this, because we have seen very high BNP level with patients absolutely not showing any clinical features of deterioration. Even now we have a patient whom we operated a hip fracture where the pro-BNP was very high. It scaled to 5,000 plus, and then but we went ahead with, we got the informed consent, went ahead and did the surgery. So in other words, it's a kind of an indicator to make yourself closely, I mean, make you and the team closely monitor the patient. But however, in hip fractures, I think the primary goal is to operate and make the patient pain-free, but increase your vigilance and monitoring.
Next question from Dr. Next question from Dr. Ashwin. Sir, continuous epidural infusion or intermittent boluses, which is better for post-op analgesia and ortho surgeries?
I would strongly recommend going for continuous infusions, because intermittent bolus can produce hypotension, and especially if it is done in a time when the anesthesiologist is not around and the waxing and waning of pain that happens. I would strongly recommend to go for elastomeric infusion pumps, which are freely available in India now at an affordable cost. I think you get infusion pumps for 1,400 rupees now. So I would recommend going in for continuous infusions.
Dr. Sanjeevani, Madam asking, leukodepletion is a wonderful procedure you are doing. How much does that filter cost in your state?
Actually, this is in the blood bank. I think there are two different companies which produce this. I think it would cost about 800 rupees, 800 or 850 or something.
Dr. Sanjana Subhash, sir, why did you say we should avoid atropine in bradycardia and give only glycopyrrolate?
No, this is, it depends upon the anticholinergic load and the delirium that happens. The atropine crosses the blood-brain barrier, and it's clearly indicated that until really indicated, you need to make sure that you don't use this drug for fear of delirium, and because delirium itself changes the morbidity and the prognosis. So if you're dealing with, if it is not responsive to glyco, then yeah, you go for atropine because it's life-saving. But in general, I'm for one would want to prevent all this by using low-dose spinal and epidural that hardly you will produce any change in hemodynamics. So that would be the goal. By using a technique which will hardly produce any change in the hemodynamics would be the first option. Second option, second thing, in case if at all there is a bradycardia, you need to decide when to treat it. In spite of the decreased in heart rate, if the mean arterial pressure is maintained and our goal is still there, organ is getting perfused, you can wait. But if the BP is getting compromised and then the bradycardia happens, you want to give a drug, then first is glyco. But if it's crashing and you're under stress, then of course atropine, because here it becomes life-saving. But as a general rule, I would prefer glyco than atropine for the possible increased in anticholinergic load and the postoperative cognitive dysfunction.
From Dr. Shobha, that elaborate on segmental spinal for this type of surgery.
Yeah, segmental spinal is another option, but for that you should have stimulating catheters, because you need to know where you are keeping the tip. It's a good option where you do it in fixed cardiac output states. You just give, like, if you want to block L234, you can keep the tip of the catheter at L3, give 1.5 ml. So totally about 4.5 ml of local anesthetic solution, producing excellent quality of surgical anesthesia and good analgesia. However, to place the tip at L3, you need to have a stimulating catheter and a peripheral nerve stimulator to keep it. It's possible. It's a good concept and can be used, but provided you have the needed equipment for it.
One more from Sanjeevani madam. Is there any method to prevent air and fat embolism, like putting big needle in marrow upstream or IVC with the very sick patients?
See, one of the things which has definitely proven is increased in the intramedullary pressure. So if you want to put a large cement load, the surgeon themselves create a vent. So to take off the pressure, and so that these cement is not under very high pressure and they do not get pushed too much into the venous sinusoids. They themselves create a vent. But as I said, with the advent of the gun, it's a very smooth flow of the cement inside, unlike the previous era where everything was manual.
Sir, from Dr. Dhananjay, what about PONV policy, sir? In special regime you use at your center, as many patients are diabetic.
Yeah, the PONV policy is what we follow is at 0 hours when you start the procedure, it is ramosetron 0.3 milligram, because it's something very effective. We find it extremely effective, and it's got a 24 hours duration of its action. And in spite of being a diabetic, we have found using dexamethasone 4 milligram. Dexamethasone 4 milligram and ramosetron 0.3 milligram is the best combination that we have used in several audits. We have seen the incidence of nausea, vomiting is decreased with this combination. The question now asked is, can we give dexamethasone in a patient who is diabetic? And the answer is yes, because not only for PONV, dexamethasone has also been tried as a component of multimodal analgesia and decreasing the pro-inflammatory release in the perioperative period, 2 doses, one at 0 hours and another at 8 hours. So that was one more indication of using dexamethasone. And the third indication is it is used as a component of regional analgesia. So in all these cases, there are several studies which indicated there is a marginal raise in the blood sugar level, but which come back to normal very quickly. So if you see the pro and con, the benefit of using dexamethasone, even in a diabetic, far outweighs the possible small elevation in the sugar level, which eventually comes back to normal. So my choice, even in a diabetic, would be 4 milligram dexamethasone and 0.3 milligram of ramosetron.
So from Dr. Sushil, can you tell us how long you keep your CSC catheters in post-op period?
Most of the catheters we remove by 2 days, 48 hours. The elastomeric infusion pump which we put in usually has got 300 ml, and they run for 48 hours. And by then, based upon our experience, except for redo hips, where the tissue trauma has been very significant, in all the other fractures, by 48 hours, their requirements are much less, and usually we remove the epidural catheter after 48 hours. But there are instances when we keep it longer, like next 48 hours, but in general, majority of them is only for the first 48 hours. And then the multimodal analgesia, especially the paracetamol, will continue for at least another week or so, but we convert them into 650 milligram of paracetamol 8-hourly.
One question from Dr. Satyajit: what to do with a patient of 80 years with ejection fraction 27%?
Now the question is what to do with a patient with ejection fraction of 27%. Number one, the surgeon has to be the competent one who can finish the surgery within 15-20 minutes. Infrastructure should be excellent. There should be a good post-operative follow-up in this patient. You should have the best of the anesthetist. And intra-arterial pressure monitoring is highly advocated. If you're very good in regional analgesia, including either a peripheral nerve stimulator or ultrasound, you can get the case done under lumbar plexus and sacral plexus block. If not, if you are not competent or we don't have the resources for that, I would still strongly advocate going in for a low dose combined spinal epidural. And only thing to keep in mind is you don't give a lot of fluids to this patient for fear of significant, because there is significant LV dysfunction, a pulmonary edema can develop. So outcomes are really good if done, the surgical time is less, blood loss is less, you managed your hypotension well, you used a combined spinal epidural, you can run an infusion of any kind of vasopressors to maintain the mean arterial pressure, give less fluids, outcomes are really good. 27 is not a contraindication to do a surgery.
So, I will pardon you because a lot of questions are coming after one by one. Please excuse us. Any guideline regarding low molecular weight heparin in geriatric and regional specialty?
Yeah, I actually spoke about low molecular weight heparin, and if there are several studies across the globe. Number one is low molecular weight heparin advocated, especially if they're immobile for a long time, and if they fall into the risk strategy, very obese, the body mass index is higher, then you go for enoxaparin on arrival. And based upon the frailty, you need to take a call, because these patients, this is something very, very, I would like to say it has to be individualized. Mechanoprophylaxis should be a must for all these patients. Chemoprophylaxis will have to depend upon the frailty. And when you use enoxaparin, it should be at a dose above the age of 8 years. It's about 20 milligrams subcutaneous once daily should be enough. There are several studies also showing that starting low dose aspirin, 75 milligram, has been found to be good in decreasing the incidence of deep vein thrombosis. So, in fact, in our center, for all total knee, not for hip fractures, we have done a large trial of using ecospirin or aspirin 150 milligram once daily for 30 days without using low molecular weight heparin in patients who are not obese. And they also had a screening venous Doppler study on the 4th day and the 7th day. And we have found even 150 milligram of ecospirin extremely effective and efficient in preventing deep vein thrombus. But otherwise, low molecular weight heparin, along with mechanoprophylaxis, a lower dose of 20 milligram. And another important thing is the patient should have a good attendant, because they have a history and tendency to fall or to have a hit on surrounding objects. They may develop a subdural hematoma. So these are the few concerns in starting low molecular weight heparin in this population.
One more question. Sanjeevani, do you do C-reactive protein levels to know the load of inflammation preoperatively?
It can be done, but it's not a great indicator, because especially in hip fractures, even if on arrival, if the CRP is high, many times you see the CRP is high, especially because they come after 3 or 4 days. Already they have a urinary tract infection, they're starting a pressure sore, but this will not come on the way of doing the procedure. So we will try all the reasons to get the procedure done early in spite of a raised CRP. We need to make sure that they're more monitored, and maybe you need to give your antibiotics for slightly longer time. But I wouldn't consider CRP as an indicator on deciding about going ahead with the surgery.
From Purnima, what is your recommendation for drugs in epidural infusion for post-operative analgesia?
Yeah, post-operative analgesia infusion, here is the opportunity to use, because it's a continuous infusion, and 0.2% tropin is a very good drug for geriatric population because of its safety profile when used as an infusion. And depending upon the frailty of the patient, if they are well built and they're good 60s and good 70s, you can add 1 microgram of fentanyl and 0.2% ropine, and you can keep the epidural infusion anywhere between, depends again, you can titrate it if you are using a multifuser, but majority of the time we use it between 5 to 7 ml per hour.
From Sanjeev, do you do lung ultrasound to know cardiorespiratory status in pre-op period?
Yeah, we can definitely get lung ultrasound done. The point of care ultrasound has come in a big way in terms of assessment, and but generally I would say that if it is not available in small centers, just a pulse oximeter is enough, and a breath holding time is enough to know the pulmonary reserve and the respiratory rate, the pulse oximeter reading, and the breath holding time would be sufficient enough to categorize the patient and the respiratory issues. And if you have ultrasound, it's well and good. You can do a point of care ultrasound to see if there is any effusion, if there is any consolidation. It just adds to it, but it may not be present across any information with new gadgets are good, but all this will only give us strategies and monitoring that needs to be done.
I think almost finished. No questions in question answer box. One in chat box. It's myself. Which procedure other than hip fractures for isolated hypertension cases can be done? You mentioned about yes.
Yeah, so actually, not only hip fractures, Dr. Sachin, I would wanted to go and you do a literature search on isolated hypertension, because patient will be very, very well controlled preoperatively. You would have seen the patient the previous day 130/80. On arrival to the table, you see him 170/100. Now, there are a lot of studies which have been done, whether you should postpone the case or you should go ahead and do the case. And it is very clearly indicated that you can go ahead and do the case, not only for hip fractures, even for other surgeries. But I want you to read more, and I want you to understand, and then take it forward. But this is for isolated hypertension. You have seen it before. Yeah, it's only for that particular thing, not for chronic uncontrolled hypertension.
Uncontrolled. Yes. Sir, it's I think all are answered. Everybody is satisfied with your answers, sir. And
I don't know whether they are satisfied or not, but whatever I spoke is whatever we do.
A lot of comments on that, excellent discussions and other things in chat box and in question answer box also, and a lot of emojis also that they are happy. So I feel that everybody is satisfied from that. It's concluding the meet. We are very much happy that you came on a platform. It's a so small branch, ICCT Nanded, that we are started this case meet, and you happily accepted our invitation to come on this
Dr.
platform.
Dr. Sachin, there is no small branch, big branch. There is a branch, there are anesthesiologists, and sharing knowledge, learning from each other, saving some lives. I think it's part of our journey. So I don't think there is any big branch or a small branch. Every branch is a branch. Every anesthetist is someone whom we should share whatever little we know.
It's your great gesture, sir. I'm really thankful to you. We are conducting this case meets regularly on Friday 8 p.m. New topics or any new speaker you want for next case meets, please mention in our YouTube channel also or in your chat box also. And I will thank you, sir, for your valuable time you gave. Thank you. Thanks once again from ISSCT, from all our members. Thank you, sir.
Thank you so much, Sachin. And it was my pleasure to share what little we have learned over years. And I think hip fractures are one they should live. They should live with grace, with elegance, not depending upon their attendance. And I think we have a huge role to play in good outcomes. So thank you so much, and
Thank you,
thanks
sir.
to
Thank you.
everyone who were part of this session. Thank you.
Thank you, sir. Thank you.